Thank you for joining me. My name is Nancy Malek, and I'm a specialist anaesthetist working in Sydney. This is a presentation I recently gave to my colleagues, designed to present the science and some of the Australian statistics around COVID. I hope this can serve as an example of medical education, because I believe that all doctors have a duty of care to learn about COVID. With that in mind, here's my presentation. I know that COVID is polarizing. So before we discuss the statistics and the science, I'd like to tell you a story. This is the story of a doctor named Semmelweis, and the legacy he left, known as the Semmelweis reflex. Dr. Semmelweis was a Hungarian obstetrician who in 1847 made some simple observations on the maternity ward. He observed that when midwives washed their hands, there was a profound decrease in the rate of postpartum sepsis and death in new mothers, from 18% to 2%. So he was really excited. And he went to his colleagues and he said, "Hey guys, we should wash our hands." But they were so offended and so resentful that they ridiculed him and banished him because he was speaking out against established dogma. They believed that disease came from bad humours and, ironically, bad air. And they were gentlemen. Gentlemen didn't have disease on their hands, let alone transmit it. So they said, absolutely not. We'll continue as we are. And so these new mothers continued to get sick and die. Now, he wasn't asking them to wash their hands with mildly scented, moisturizing, skin-friendly detergents that we use. No, he was suggesting smelly, unpleasant chlorine solutions that were inconvenient and uncomfortable. So he was ridiculed and banished, and he ended up in a mental asylum. The biggest tragedy is that he died of sepsis from an infected wound that he sustained after being beaten by the asylum guards. It was several decades later that Louis Pasteur put forward germ theory. And after that, a surgeon called Lister came along and said, "Hey, we should wash our hands." And this time, everyone said, "Yes, absolutely, let's wash our hands." And they called Lister the father of modern surgery. So back to the Semmelweis reflex. It's the reflex tendency to reject new knowledge or even scientific evidence when it contradicts established knowledge, beliefs, norms, or paradigms, especially when the knowledge or evidence is inconvenient or uncomfortable. So here we are in 2025, in the 6th year of a global pandemic with a novel pathogen, and it seems that history is repeating. The outline for tonight is to first look at the Australian mortality statistics, comparing deaths from COVID with road fatalities. Then we'll start with the basics about the virus, and then acute and chronic disease, including mechanisms. Then I'll present 2 research articles related to COVID's effect on the brain, and then move on to how it spreads, and finally, some solutions or mitigating strategies. How do we mitigate against something we can't see? Here's a 2-minute video created by the John Snow Project in 2023, which is still very relevant.
When an Australian dies on our roads, it's a tragedy. We hear their names. We see their faces. They're not just a number. They are a reminder to do better. We choose to prevent. We redesign, we innovate, we test, we secure, we check, we double-check, we warn, we enforce, we fix, we maintain, we train, we look, we wait. We use multiple layers of defence every day to prevent every road death we can. But when an Australian dies of COVID-19, it's not a tragedy, it's just a number too big to ignore. Right now, COVID-19 is already 12 times more deadly than our roads. Yet our government has chosen to ignore it. Relying on current vaccines alone is never going to work. But we can prevent infections in the first place by wearing well-fitting respirators when sharing air, by cleaning the air with filtration and ventilation, by supporting people to test and isolate when sick. Because living with COVID is not really living.
It's an interesting discrepancy, isn't it? I contacted the Australian Bureau of Statistics, and they very helpfully responded with these numbers. By the end of 2024, there were almost 22,000 deaths from COVID in Australia, compared to approximately 6,000 road fatalities in the same time period. Isn't it interesting that we've decided to live with COVID? So, we've talked a bit about numbers. Now let's look at the science. We're starting with the basics so we can build on this knowledge in the future. Terminology first. Severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is the virus responsible for COVID-19 or COVID. For simplicity, I'll be using the term COVID to mean both the virus and the disease. Now, structure. It's an enveloped RNA virus, so called because the surface spike proteins give it a corona or crown-like appearance. Its average size is 100 nanometers in diameter, equal to 0.1 micrometers. And this becomes important when we talk about spread. How does COVID infect? Each spike protein consists of 3 monomers with 2 subunits each, S1 and S2. The S1 subunit contains the receptor binding domain for the ACE2 receptor. After S1 binds to the ACE2 receptor, together with the TMPRSS2 protein, the S2 subunit undergoes conformational change. This allows merging of the viral envelope with the host cell membrane. The virus then replicates inside the host cell, new virions get released by exocytosis, and then new host cells can be infected. The pathophysiology is complex. Put simply, viral replication triggers cells of the innate immune system to release inflammatory cytokines, and these recruit adaptive immune cells. Concurrently, COVID infects endothelial cells, which causes inflammation, activates the complement system and platelets, and can result in the formation of microthrombi. During the acute phase, the interplay between viral replication, immune function or dysfunction, and endothelial dysfunction determines disease severity, from completely asymptomatic all the way to multi-organ failure and death. Where are ACE2 receptors located? In the respiratory system, they're on the ciliated epithelium of the nose, pharynx, larynx, trachea, and bronchi, as well as goblet cells and type 2 alveolar cells. In the cardiovascular system, they're on cardiac myocytes, and most importantly, endothelial cells, because endothelial cells are everywhere. In the central nervous system, they're in the olfactory bulb, neurons, astrocytes, dendritic cells, and glial cells. They're in the gut, the liver, and gallbladder, in the kidneys and adrenals, in male and female reproductive organs, and in skeletal muscle. COVID can enter and infect any cell which has an ACE2 receptor. I hope to dispel some common myths tonight, and the first one is that COVID is a respiratory disease that's confined to the lungs. In fact, COVID is a multi-system disease that affects multiple organs and blood vessels. How is COVID different? Here are the mechanisms of some common viruses for comparison. Influenza binds via sialic acid receptors in the upper and lower respiratory tract. RSV binds via nucleolin in airway epithelial cells. Rhinovirus binds via ICAM1 in nasal epithelium and upper airway lymphoid tissue. And once again, the numbers are very telling. From the Australian Bureau of Statistics, here are deaths from influenza and COVID in Australia from 2022 to 2024. Each year, deaths from COVID have outnumbered deaths from influenza by a factor of between 5 and 33 times. Here's our next myth. COVID is like the flu, or it's just a cold. In fact, COVID is mechanistically different to, and more lethal than, influenza, RSV, and rhinovirus. How does COVID cause harm beyond the acute phase? Now we move to the chronic phase of COVID. It was first termed long COVID by Dr. Elisa Perego in May 2020 as a hashtag on Twitter. It's also called post-acute sequelae of COVID, or PASC. The most comprehensive definition of long COVID was formulated by the National Academies of Sciences, Engineering and Medicine, who were tasked with developing an improved definition for long COVID by the American Department of Health and Human Services. That definition is, in brief, the persistence of one or multiple symptoms or conditions after a COVID infection that last for at least 3 months as a continuous, relapsing and remitting, or progressive disease state that affects one or more organ systems. The COVID infection can be confirmed or even just suspected. Some important things to note. Long COVID can follow asymptomatic, mild, moderate, or severe COVID. Anyone can be affected. In fact, the vast majority of long COVID cases follow a mild COVID infection. It can be continuous from the time of COVID or have a delayed onset, sometimes weeks or months after apparent recovery. Over 200 symptoms have been described. There's currently no available diagnostic biomarker, so it's a clinical diagnosis. And although novel therapies are in development, there are no validated or effective treatments. Now let's look at the 4 main mechanisms thought to underlie long COVID. The first mechanism is viral persistence. Viral persistence causes chronic inflammation and ongoing symptoms. Viral proteins and whole live virus have been found in multiple organs, including but not limited to the brain, heart, lungs, liver, lymph nodes, reproductive organs, and muscles. The second mechanism is immune dysregulation. One of the many features of this is chronic T-cell activation, leading to T-cell exhaustion and reduced CD4+ and CD8+ effector memory cells. COVID can also trigger autoimmunity. Weakened immune systems are becoming increasingly common. The third mechanism is reactivation of dormant viruses and microbiome dysbiosis. Reactivation of any latent virus can occur, such as Epstein-Barr virus, shingles, or cytomegalovirus. There's also research to suggest that any dormant infection can be reactivated, such as Lyme disease, Bartonella, and tuberculosis. Dysbiosis can cause local gastrointestinal issues, as well as systemic effects, such as contributing to neurological symptoms via the gut-brain axis. The fourth mechanism is macroscopic or microscopic direct tissue damage, affecting organs where there is chronic inflammation and mitochondrial damage and dysfunction, and affecting blood vessels. Endotheliitis contributes to the formation of fibrin amyloid or fibrinoid microclots, which can obstruct capillaries and lead to cell hypoxia. This is an evolving and dynamic area of research and will hopefully lead to an even clearer mechanistic picture in the near future. This is a list of just some of the symptoms and conditions that can be seen in long COVID. Recall that over 200 have been described. Cough, shortness of breath, chest pain, palpitations, myocardial infarction, cognitive impairment that's been likened to drink driving, memory and concentration problems, fatigue that's not relieved by rest, sleep disturbance, headache or migraine, dysautonomia, including inappropriate sinus tachycardia or POTS, postural orthostatic tachycardia syndrome, anxiety, depression, tinnitus, hearing loss, DVT or pulmonary embolism, stroke, diabetes, which is generally type 2 in adults and type 1 in children, autoimmune conditions, mast cell activation syndrome, alopecia, abdominal pain, change in bowel habit, muscle weakness, muscle or joint pain, osteoporosis, erectile dysfunction, menstrual abnormalities, and post-exertional malaise. This is an interesting phenomenon. It causes worsening of or new symptoms up to 48 hours post-physical or even cognitive exertion, usually lasting days to weeks or much longer. So this means a person will feel that they have the energy for a task, whether it's physical or cognitive, then they'll do that task, and 24 to 48 hours later, they crash, with long-lasting worsening of their symptoms or the onset of new symptoms. This is a very debilitating aspect of long COVID, and graded exercise is not the answer. As doctors, we need to consider long COVID as a differential diagnosis for these symptoms and conditions. So next time, ask yourself, could it be long COVID? I hope you can appreciate, based on mechanisms and symptoms and conditions we've discussed, that long COVID can affect every organ and every organ system, most concerningly, the brain and cardiovascular system. But it's important to know that even apart from long COVID, there's a spectrum of asymptomatic organ damage that's driven by viral persistence in immune-privileged reservoir sites and chronic inflammation. Individual susceptibility varies based on predisposing factors and pre-existing conditions. For example, subclinical hypothyroidism might become overt, mild tinnitus might become more noticeable, or impaired glucose tolerance might progress to diabetes. There can also be new-onset hypertension, dyslipidemia, and renal dysfunction. And this asymptomatic organ damage is also cumulative. So how big is the risk? The Australian Institute of Health and Welfare has estimated that 5 to 10% of adults infected with COVID may develop long COVID with each infection. My focus is on adult COVID, but a systematic review and meta-analysis led by a professor of neuroscience and the Harvard School of Public Health found the prevalence of long COVID in children to be 25%. The prevalence varies between studies, making it difficult to establish a definitive rate. But the most common symptoms are fatigue, mood symptoms, and sleep disturbance. And children can also get shortness of breath, memory loss, concentration problems, headaches, orthostatic intolerance, abdominal pain, muscle and joint pain, and post-exertional malaise. So from this, How much long COVID are we missing? Here's our next myth. COVID is mild and self-limiting. In fact, the risk of long COVID is 5 to 10% per infection, and the risk is cumulative. Cumulative risk means that the risk of long COVID increases with each infection, and it doesn't return to zero. For example, if the cumulative risk is 5% per infection, it jumps to 40% after 10 infections. And if the cumulative risk is 10% per infection, it jumps to 65% after 10 infections. Now let's look at the evidence. I have two studies to discuss about COVID and the brain. The first one is a study from the UK Biobank, which is a public health database in the UK. Researchers performed MRIs on 401 patients, both before and after their COVID infection, as well as in 384 matched controls who had no record of COVID. It was published in the journal Nature in 2022. The main findings from these figures are that the COVID group had a 1 to 2% greater reduction in grey matter thickness of the parahippocampal gyrus compared to the non-COVID group. This area of the brain is involved in making integrated decisions using sensory and emotional information. They found a similar pattern in the orbitofrontal cortex, with a 2% greater reduction in grey matter thickness compared to controls. This area of the brain is involved in spatial and episodic memory. Now, you might think that these changes are small, but normal aging results in only 0.2 to 0.3% change per year. So in effect, these findings indicate that COVID can cause a 10-fold increase in the rate of brain aging. They also undertook cognitive tests on both the COVID group and the controls, called Trail A and Trail B. For Trail A, the COVID group took 7.8% longer to complete the test. Even after excluding 15 patients who'd been hospitalized with COVID, the COVID group still took 6.5% longer to complete the test. For Trail B, the COVID group took 12.2% longer, and about the same even when the 15 hospitalized patients were excluded. In other words, the COVID group had worse executive function. Isn't that interesting? Now for the second brain study. This study was published in the New England Journal of Medicine in 2024. 800,000 adults in the UK from the NHS were invited to complete an online cognitive assessment. They'd all tested positive to COVID between May 2020 and March 2022. Of 112,000 who completed the test, 102,000 were included in the study because they were at least 12 weeks post-COVID infection. The cognitive domains assessed by these tests have previously been implicated in post-COVID syndromes. These domains include immediate memory, 2D mental manipulation, spatial working memory, verbal analogical reasoning, word definitions, spatial planning, information sampling, and delayed memory. This study found that people who've recovered from mild COVID lose about 3 IQ points. Those with long COVID lose 6 IQ points, and patients in the ICU because of COVID lose 9 IQ points. How interesting. Now let's talk about transmission or spread. This one's our most dangerous myth. COVID is spread by droplets. That's what we were told at the beginning of the pandemic. In fact, COVID is airborne. And how do we know it's airborne? The Lancet published 10 reasons in 2021. Number 1, superspreading events have been documented. Number 2, there's higher spread indoors, especially when poorly ventilated compared to outdoors. Number 3, infections have occurred in hospitals despite strict contact and droplet precautions. Number 4, COVID has been identified in air filters and building ducts. Number 5, Viable COVID has been detected in the air in lab experiments. Number 6. Studies where healthy animals are connected via an air duct to COVID-positive animals results in transmission. Number 7. Long-range transmission has been documented in quarantine hotels between people in adjacent rooms. Number 8. Asymptomatic and pre-symptomatic infection has been documented. Number 9. There's no strong, consistent evidence to refute airborne transmission. And number 10. There's limited evidence to support droplet or fomite transmission. I wonder if you can start to think about COVID like cigarette smoke, except it's invisible and odorless. And remember when we thought that aerosol-generating procedures were limited to intubation and extubation, or jet ventilation, or using a nebulizer or high-flow nasal prong oxygen? Well, that's not what the science says. Anything that moves air through the respiratory tract is an aerosol-generating activity. Breathing, talking, shouting, sneezing, coughing, whistling, singing, playing a wind instrument, laughing. If it moves air through the respiratory tract, it also moves aerosols. This is a diagram that shows the continuum between aerosols, which measure less than 100 micrometers, and droplets, which are larger than 100 micrometers. Once inhaled, aerosols move with respiration. Larger aerosols get deposited in the upper airway, and smaller aerosols get deposited in both the upper and lower airways. Droplets, on the other hand, can't be inhaled. They're too big and too heavy. They're subject to gravity and they fall rapidly. This graph shows the time it takes for aerosols of various sizes to fall to the ground from a height of 1.5 meters. For a 100 micrometer aerosol, it takes 5 seconds. For a 5 micrometer aerosol, it takes 33 minutes. And for a 1 micrometer aerosol, it takes 12.2 hours. Recall that an average COVID virus aerosol is 0.1 micrometers in diameter. That means that in a poorly ventilated space, COVID can float and linger for hours. Think of COVID like cigarette smoke, except it's invisible and odorless. Who can transmit COVID? The National Health and Medical Research Council commissioned an Australian study in 2020, back when gold standard PCRs were readily available and reporting of positive cases was mandatory. They tested asymptomatic close contacts and found that 30% of people were pre-symptomatic but infectious, and 10 to 15% of people were asymptomatic but infectious. The Lancet from 2021 quotes almost 60% asymptomatic transmission worldwide. That has really big implications for infection control. According to the New England Journal of Medicine, on average, 75% of people are infectious for more than 5 days, 50% of people are infectious for greater than 8 days, and 25% of people are infectious beyond 10 days. I'd like to pose some rhetorical questions. How can you tell if someone has COVID in the absence of a positive test? Can you see that they have a sore throat? Can you see that they have that feeling you get behind your nose before the congestion starts? Can you see that they have a headache or a low-grade fever or some myalgia? Conversely, how can you tell if someone doesn't have COVID? How do you know that the person standing beside you in the operating theatres or behind you at the coffee kiosk doesn't have COVID? Is there a way to tell, just by observing? This is an interesting myth that I was asked by my colleagues to address. Only patients can transmit COVID. In fact, anyone can transmit COVID. Patients, staff members, anyone, including those with a false negative RAT or those who are asymptomatic, pre-symptomatic, mildly symptomatic, floridly symptomatic, or even post-symptomatic. Why do we run to get PPE when there's a patient who's COVID positive or a close contact, when the person beside you might have COVID? I want to talk briefly now about hospital-acquired infection, because I think it's important to put this in context. Hospital-acquired infection is obviously a serious problem. Data from the Victorian Healthcare Associated Infection Surveillance Coordinating Centre found that in 2022 to 2023, the number of hospital-acquired cases of Staph aureus bacteremia was 550, hospital-acquired MRSA or MRSA was 273, and hospital-acquired Clostridium difficile was 1,600. In comparison, there were nearly 23,000 cases of hospital-acquired COVID in the same time period, and just over 1,200 who were admitted to the intensive care unit. Isn't that interesting? Think about it. We use contact precautions to protect against MRSA and C. diff, but what precautions do we take to prevent COVID transmission? Especially since we know that it's a much bigger problem and at least 40% of COVID transmission is from people who are asymptomatic. What are we doing to prevent our patients getting COVID in hospital? So how do we mitigate against COVID? As per the Swiss cheese model that we're familiar with, all mitigation strategies are imperfect on their own. Multiple mitigation strategies are required to improve success. First, we need to talk about masks. Masks are politicized and stigmatized and personalized, but let's look at the science. Here's a comparison between surgical masks and N95 respirators. They're called respirators because they offer respiratory protection. For simplicity, let's call them N95 masks. A surgical mask is fluid resistant, but it's just a cover. It gives you very low protection against airborne pathogens like COVID because it's simply designed to stop liquid splashes from the outside and prevent droplets escaping from the inside. Surgeons wear them while operating to protect their faces from bodily fluids and to prevent their droplets from landing on a patient. They don't create an airtight seal, and air leaks in and out along the path of least resistance between the mask and the face. At best, they offer imperfect source control. But remember, they're just a cover. N95 masks provide high COVID protection. They filter out more than 95% of small particles, including COVID virus, and they have an airtight seal with minimal leakage when worn properly. They consist of multiple layers, and they use both mechanical and electrostatic filtration. So even if COVID is smaller than the spaces between the mask fibers, they still get trapped, and they're blocked from entering your respiratory system. A fit-tested and fit-checked N95 mask protects you from COVID. But even more importantly, they provide bidirectional protection. That means they protect you and also the people around you. Here's the myth. Surgical masks protect the wearer from COVID. In fact, surgical masks do not protect against airborne pathogens. Ventilation is one of the most important mitigating strategies in reducing airborne pathogens. In terms of natural ventilation, airflow moving through a space is more effective than unilateral airflow. Let COVID and other airborne pathogens out, and let fresh air in. CO2 monitors are useful for assessing the adequacy of ventilation and are easily portable. They measure ambient carbon dioxide in parts per million. The risk of aerosol transmission increases with increased CO2. You should always aim for less than 800 parts per million, at which point 1% of the air you're breathing in has been breathed out by someone else. When the carbon dioxide goes up to 10,000 parts per million, 24% of the air you're breathing in has been breathed out by someone else. So the question is, If you wouldn't drink dirty water, why would you breathe dirty air? It's interesting that we take clean water for granted, but pay little attention to the cleanliness of the air. High-efficiency particulate air, or HEPA purifiers, remove multiple different pathogens from the air, including viruses like COVID, and also mold spores, dust, pollen, pet dander, and smoke. You can also get small, portable HEPA purifiers. They're great for the car, or as an extra safeguard when you're in an indoor space, or even a crowded outdoor space. During lockdown, we spent years fighting over toilet paper and washing our hands, when really we should have been fighting over air purifiers and cleaning the air inside schools and daycare centres so that children could go back to a safer indoor environment, and cleaning the air inside every public building and every hospital and our own homes to reduce the pathogen load in the air. We've already discussed N95 masks, but let's recap because this is important. N95 masks provide high COVID protection due to their airtight seal, multiple layers, and mechanical and electrostatic filtration. And they offer bidirectional protection against COVID and other airborne pathogens. ATAGI, or the Australian Technical Advisory Group on Immunisation, are in charge of our vaccination protocols. Our current Australian guidelines recommend annual vaccination against COVID if you're aged 18 to 64, and 6-monthly vaccination for those aged over 65 or immunocompromised. However, vaccination between 6 months and 18 years of age is allowed only if there's an underlying medical condition. So a huge proportion of the population is unvaccinated or undervaccinated. And this ignores the fact that anyone can get long COVID. This myth is incredibly widespread. Hand washing and surface disinfection are reliable ways to reduce the spread of COVID. That would be like saying, if a person starts smoking in your living room, you could wash your hands and disinfect some surfaces, and that would get rid of the smoke. But we know that's not true. Because in fact, COVID is airborne, so airborne mitigation strategies are required. So you'd probably open a window or a door, or even turn on an air purifier. But washing your hands or disinfecting surfaces isn't going to help. Remember that COVID is like cigarette smoke, except it's invisible and odourless. Here are tonight's key messages. COVID is a multi-system disease. It can enter and infect every cell that has an ACE2 receptor. Every COVID infection, even if it's asymptomatic or mild, carries a cumulative risk of long COVID. COVID can cause changes in brain structure and function. COVID is airborne. Think of it like cigarette smoke, except it's invisible and odourless. Mitigation strategies must be airborne strategies, and multi-layered mitigation strategies improve success. Long COVID is associated with multiple sequelae that can have significant impacts on health, function, and quality of life. Ask yourself, could this be long COVID? COVID has a spectrum of harm, which includes asymptomatic organ damage and long COVID. The only way to avoid long COVID is to avoid COVID. I'd like to say a heartfelt thank you to my creative team at Antiviral for bringing this presentation to life. Their graphics and videos, alongside their advice, support, and commitment to science, have been invaluable. We are fortunate to be part of a global, COVID-aware community dedicated to turning evolving evidence into practical education for both healthcare professionals and the public. While the story of Semmelweis was a tragedy, The Semmelweis reflex is a powerful legacy, a reminder to question our resistance to new evidence so we can move beyond discomfort and inertia toward open-mindedness and discernment. Public health change takes time. We've seen this with asbestos, with smoking, and with hand washing. But we know the delay is always deadly. Today, airborne transmission challenges long-held dogma, just as hand hygiene once did. The evidence is clear. COVID spreads through the air and causes cumulative harm. The time to act is now.